Great having you on the podcast here today. How's it going?
It's going well. It's an honor to be here. Thank you.
Yeah, excited to have you. Let's dig right in. First off, um, would love for you to, for those that are maybe unfamiliar with Chronic Care IQ, would love for you to tell us, just give us the kind of a brief overview.
Yeah, so Chronic Care IQ is a platform that my co-founder and I started developing in 2015 to keep doctors and patients connected between visits. We follow the premise that healthcare is communication, right? The changes in the tools and the pharmaceuticals and procedures that are available, they continue to evolve. But what healthcare really is, it's a person with training and a person with needs meeting and being able to communicate. And its genesis came from when I was diagnosed in the hospital with type 1 diabetes at the age of 30. I left the hospital basically with two prescriptions and a pep talk. I hadn't seen a doctor since a high school physical and said, go get a doctor. And so I went from not having an interface with healthcare at all um, to now having to navigate healthcare. And I thought um, this should be a little easier, especially when you have to give yourself, you have to poke 5 holes in yourself every day. I thought we should tighten that up a little bit. And essentially that's where I've been. That's how we do what we do, and it's helped out a lot.
And I would like to focus on, when people think of Chronic Care IQ, why? Let's talk about. Love the story, by the way, and how that led in. I always like this kind of question. Why Chronic Care IQ?
Well, it depends on who you're asking.
So
If
let's
it's
go from. That's a great question. Let's go from the from. Let's unpack it from kind of two different angles, if you don't mind.
mhm.
Um, so like in terms of like two key stakeholders, can we go from that, like practice patient? Does that
Yeah,
work?
so let's look at that, right? So Medicare has known for a long time, everybody's known for a long time, that aging boomers have chronic diseases, and chronic diseases account for 86% of our, or 90% of our US healthcare costs. And it's not so much the cost of managing chronic diseases, it's the cost of dealing with poorly managed chronic diseases. So there is a payer stakeholder that says, hey, how do we fix this? How do we better manage chronic diseases? And obviously, you have to involve the doctors that know how to provide care. You have to be able to involve the patients that live with the problem, and then you have the practices where that patient healthcare is happening, and you have patients that periodically visit those practices and nurses that spend a lot of time in between visits trying to care for those patients. So you have a clinical investment at the doctor level, you have a patient investment at the patient level. Are they going to participate in anything? You have a nursing involvement because they have to keep the patients well, and then you have an administrative involvement of, can I even absorb this into my practice with everything that's going on? The vast majority of medical practices are small businesses. So, um, in speaking to your question, who are the stakeholders? I primarily talk about nurses and patients because high needs patients, which I consider myself one because I have to take shots every day, um, they're very similar to some of our patients with multiple comorbidities, multiple medications. They're, you're almost waiting for another shoe to drop, right? Frequently hospitalized with heart failure or with pneumonia and rheumatoid arthritis and 11 medications and occasional depression, that type of thing. So who are those people? Well, um, it's tough. It's tough to navigate healthcare. Even as a young technology professional, it was hard for me to navigate healthcare. So we know that it's hard for our more seniors, especially when they've heard that they have a new diagnosis, right? They've heard the word cancer, or they're leaving the hospital after having a heart attack, or they've been diagnosed with heart failure. There's all of a sudden people are ready to take health a little more seriously than they were when they could have 5 years ago, started eating better, walking, exercising, etc. So this is what we get, right? When we can engage patients and we can know what their symptoms are on a regular basis, we can keep them stabilized. We can keep them home. When they trend in the wrong direction between visits at the clinic, we only find out they're in the hospital after they needed to be in the hospital. Whereas if you have a connected patient and you have an infrastructure that connects to those patients for you and keeps you updated automatically, you're seeing that happen almost in real time. You can get engaged sooner. When you can get engaged sooner, it's much less work, right? It's the ounce of prevention. If we can adjust your diuretics and get your heart failure uh, mitigated before it results in decompensation, um, I have a much better luck, not only with your current outcome, but with your general health. Nurses love that, right? Because now they're working proactively for patients instead of reactively with patients, getting a patient out of the hospital, doing a med reconciliation, reviewing all the change, the new things that happened when they got in the hospital, and patients don't bounce back as far. So the nurses are huge advocates because they get to be involved sooner. The doctors are massive advocates. I say this all the time. Nobody would give up a decade of their life to become a doctor if they didn't truly care about people. And instead of the finding out too late, knowing ahead of time, based on a dashboard of red, yellow, and green patients who needs help, it's rewarding. Beginning in 2015, Medicare started paying for the amount of time that practices spent on non-face-to-face clinical activities for these patients. So if I'm refilling a high-risk patient's medications, if I am coordinating a visit to a cardiologist or to a rheumatologist or a pulmonologist, etc., all of the things that they're doing in between visits to keep those patients well are now paid for in 20-minute increments of time. Since 2015, they started with one code that did that. They now have over 25 monthly recurring codes that do that. And this next year, they're going even farther with 3 new codes that lower the barrier to billing significantly. So the government stakeholder is pouring money into non-face-to-face care to keep patients out of that vicious cycle of disease progression. The clinician stakeholder is now able to generate more revenue for the practice, in many cases for work that they were already doing, and nurses will tell you that it makes their job easier. It was a long answer
No, no,
to only a few questions that you
it was
asked, but
perfect. No, I'm glad you broke it down. I mean, some I was gonna. I like when that happens because then you took 1 or 2 follow up questions away, from, which was I don't care. You gave me what
yeah.
I wanted. So when we also talk about, we talk a little bit about differentiators for chronic care IQ, and then maybe some of the proof points that you found with some real life examples, if possible, or data.
Yeah, I think one of the biggest differentiators is we started the business. My co-founder and I started writing code in 2014. And it was when I learned that 1 out of 4 heart failure patients is rehospitalized. I thought, how can that be possible? As much money as it costs to get a heart failure patient out of the hospital, how can we have a 25% recidivism rate, right? It was shocking. And the more I learned about it, there was a doctor at UPenn that said, hey, you should figure this out. The more that I learned about it, the more I realized it can't be figured out, right? Because there's certain demographics are more prone to rehospitalization, but there's nothing predictive, right? In many cases, it's not even the same diagnosis that has them back in the hospital. We know it generally happens within the first 2 weeks, but there's a lot that happen in the next 2 weeks. And there's even some that happens over the next 90 days. We just couldn't find enough reliable information, right? You can't automate that anything that you can't duplicate. And there was nothing to be able to duplicate. So I went back to that doctor. I said, look, until I can get closer to these patients, we don't have, there's nothing that we can fix. Um, and I was standing in line at Home Depot. This was probably early 2014. I was standing in line at Home Depot. It's the first time I've ever seen SurveyMonkey. And a mother that was uh, at the same grade school where my daughter went to school was doing a survey on the phone. And I asked her what that was. She showed me. And then all of a sudden I realized, hey, that's how I can get closer to the patients. I can ask them, are you short of breath today? Are you have you had more good days or bad days this week? When was the last time you got dizzy standing up? The when we did our patent search for things like that, there was nothing in the patent library, absolutely nothing. And we realized, okay, this is novel. This is something that could get used, and we just dove right into it. Spoke to as many nurses as we could speak to, and I knew quite a few. And said, okay, how do we do this? What do we need to ask? What do you need to know to keep a patient out of the hospital? And that's how we started. We built an app, and the nurses will say on patient discharge, all right, this was back when you had to know your Apple password to download an app, right? They're much more prevalent now. It's much easier, but we would we would say simply download this app and answer these questions when they show up on your phone. So I think you had asked a question about how are we novel. We're the first one to go directly to that patient and get those answers to specific questions relevant directly to the healthcare and what they were experiencing at the time. And we had a huge response rate. And patients have been they're very sticky, right? Because it solves, I guess, that internal feeling a little bit of helplessness is like, do they know what's going on? Do I need to call? Do I need to ask this question? Should I do this? Should I do that? So as patients, they prove that they really want that higher level of care, even though it's a machine that's doing it, right? So it's the computer that does the outreach. Then we took it one step further and we said, okay, let's categorize these changes, right? How did they answer the questions today versus yesterday? And then we changed to how do we incorporate new questions based on how they answered the previous questions. And we were able to collate those patients' responses on a color-coded dashboard so those doctors could know when, and it's nurses, it's really a triage tool. So those nurses could know when they needed to get involved. So the first thing that we did that hadn't been done is we automated and digitized patient outreach in a fashion that was reliable to get patient responses. The early returns on that were a 29.4% reduction in all-cause hospitalizations. It was with Ascension data at one of the first practices that we installed. So that was novel, right? And if you think about it, it's not really that novel. If the doctor has better communication with the patient can get better care. What was novel is that we digitized it and we went to the patient and we took it. We didn't wait for them to show up or wait for them to call or leave it up to them to diagnose themselves that they needed to call their doctor. So that was the first thing. And that proved to be very successful. The first place that we were novel was we went directly to the patients, right? We asked them questions relevant to their specific situation, and we discovered they were very eager and dependable in responding, as they had just been through some type of an event, either a hospitalization or a new diagnosis. The second place where we know that we are novel is we created that platform in a customizable fashion. So I wasn't just able to track heart failure patients. I could track hypertensive patients. I could track heart failure patients with hypertension or rheumatoid arthritis or depression or this constellation of chronic diseases and specific concerns. So since it was customizable, those nurses and those doctors on our platform have now created over 600 different clinical monitoring protocols for patients. We even had a group in Arizona that was close to the Mexican border ask discharged patients how many times they ran their air conditioner that week. So I couldn't understand that question at all, right? Air conditioned air, as far as I know, isn't clinically indicative of a better quality of breathing. So I asked them why they did it, and this was a big moment for me in building the business. And the director said, "Well, we don't want to know really if they're using their air conditioner. We want to know if they're broke, because if we've discharged them and they're not using their air conditioner 6 miles from Mexico, they're probably not coming back for their follow-up appointment. They probably didn't pick up their medications. They might not be food secure. They might having to also be caring for another loved one, and we can get our medical social workers to address those patients that will have exacerbated clinical needs. And um, that ability to customize the platform to what is needed in a specific environment, and it might not be something we've thought of, but we're not the end all be all heavy thinkers in the world. That makes it very unique. You can apply it directly to your situation, and you can take it off the shelf for high risk pregnancy in rural locations. You can take it off the shelf for social determinants of health. You can take it off the shelf for patients discharging with pneumonia that you're specifically worried about, or sepsis discharges. And it can really be fine tuned to the population and the highest risk cohorts that population has. That's a second area that made it unique. So we went out to the patients, and then we made it customizable so it could be deployed at a local level. When Medicare said we're going to start paying for doctors to do this in increments of time, right? So Medicare pays based on the amount of non-face-to-face time a practice, the whole practice, spends on the patient, not just the doctor, not just the nurse, but the MAs, anybody performing clinical activities, non face to face for that patient, right? Getting them in for an image, for reviewing their labs, pajama time in the evening, medication refills, all of those things, they count. So we thought, well, where do staff spend their time if they're not in the room with a patient? Well, they spend it in the EHR, and they spend it on the phone. So that if we have to track time, it's not just the time you spend looking at how the patient responded to these questions or what their blood pressure has been over the past week. It's also how much time you spent in the EHR caring for them and on the phone talking to them, or talking to their daughter, or talking to their assisted living facility. And that's novel, right? So we integrate to the phone systems, we integrate to the EHRs, and we capture all of the activities that are already taking place. And we layer monitoring on top of that so that we get the real time valuation of those high risk patients. And that adds and makes it a very, not only lucrative for Medicare to prevent 30% of hospitalizations, but it makes it the average, I think, last month was $103 per patient per month. Out of the hundreds of thousands of patients that are enrolled, that was the average reimbursement. And if you look specifically at the patients out of that big number and you ignore the ones that didn't bill at all, the average reimbursement is $153 per patient per month. Now, when you start to think, okay, a doctor has 100 to 200 of these high risk patients, well, now you're talking about $10,000 to $20,000 a month in additional revenue, in many cases for work that they're already doing, for less of a pressure cooker because we're not constantly reacting to all of these calls that are coming in. And it, it's turned out to be a, a game changing way for doctors to add a higher level of care to their practice that financially benefits the practice and reduces stress.
In terms of what's next, uh, what's what really excites you about what's next for the business?
Well, they're two different questions. So what's next for the business is we're now getting, it's a demand pull environment. We're getting larger health systems that say, hey, we've got 2,000 doctors, 1,100 of them would be relevant, and we want to do everything from A to Z. So we haven't announced them yet, but we have two um, really exciting health systems that everybody knows rolling out right now. And what's next for the business? We want to make sure that we get that right. We have practices. The largest one we have has 71 locations. It is an FQHC in Arkansas. It's really well run. They do everything for those 71 locations the same way. That's not going to last, right, when we drop into a 2,000 physician environment, because it's not 2,000 doctors in the same building on the same assembly line. It's 500 4-doctor practices all over 3 states, and those smaller ecosystems, and then how they manage up, the enterprise traditional things like, how do we look at this window? How can we make sure everybody has access to this patient because they're relevant to my practice, but HIPAA won't let me have access to all, the 100,000 patients across 3 states. So that's a really big development feature that we're working on right now. Another one is there's new codes called APCM, where if patients meet three three separate tiers of thresholds, the practice can get reimbursed and they don't have to track any time. So now it's activity based, not time based. So we've got a lot of development. We're already doing it, right? We always take the month of December off just to develop and incorporate the new codes, right? So we've dealt with the last 25, and there's 3 pretty big ones this year. I am excited about that. I think that'll drive market adoption. And then the third thing is, how are we going to use AI? And I don't mean AI in terms of diagnosing patients. I mean AI in terms of, are we asking the right questions, right? We've got dozens and dozens and dozens of millions of patient responses over 10 years to questions, and we can loop them, get the outcome of, did their status change based on how they answered these questions? And we can see how their protocols were changed over time. So once we can really start crushing that and get that in uh, a language model that we can read, we can do significant improvements in getting better, even getting better information from patients. And I think um, that's really more machine learning than what's known as quote unquote AI, but AI does get misused a lot. Um, that's I'm passionate there, right? It's that, am I asking the right questions to begin with, right? If I can look at their entire profile of chronic diseases and I can see what's been evolving because we're plugged into that EHR. One thing we discovered with phone calls is that a change in call patterns is indicative of risk by itself, right? That's something else that's novel that other people haven't really unpacked yet, and it kind of surprises them when they hear it. But then when you think about it, like, makes sense. Been hundreds of millions of phone calls and 10 years of analyzing them, whether it's call duration or call frequency. There's so much that virtual care is going to improve. I'm generally not as concerned about the future of healthcare as a lot of people are, because we haven't even scratched the surface on what we're going to be able to do once patients become reliably involved like they are with our platform.
Matt, I want to thank you so much for joining us here on the podcast today. Look forward to future conversations, but thank you so much.
Thank you, Jared. I appreciate it. Grateful to be here.